Thank you, Mr. Chairman. I think I'm going to address my remarks primarily to Mr. Slavitt, if I could, please. Last fall, I asked you if you could get back to us on why the premiums are so high in West Virginia. We have the 7th highest premium rate in the country. We've not heard back from you since last fall, almost a year ago. You're still waiting for that call about it, because we only have one exchange in the state, and we've seen the premium increases logarithmically continue to increase. So I need that answer. I'm expecting that answer, but I'm also saying that look, this past year we had a 24% hike in our premiums, and now they're excuse me, that's what we had was 24. Then this year there was approval of 32% increase, and this coming year we've had a small group trying to penetrate to give a second option to West Virginia, and they're asking for a 49.8% increase, and from what we understand, they're likely going to get it. So my question in part to you is, what's the incentive for the regulators in West Virginia or any other state to hold down premium increases if we're going to be subsidizing so many of them?
So thank you. You know, I would say on the one hand, the great news in West Virginia is that the uninsured rate has dropped from about 17% to about 7.5%. On the other hand, as you point out, we are concerned with the costs of health care, particularly in rural America. It has always been the case. This is not an ACA phenomenon. The lack of competition in some parts of the country are areas that we need to address. I think some of the protections in the ACA do help speak to the issue you raised. So, for example, if a insurance company were to charge too much, they're obligated to give back in rebates to the
I don't know
consumers.
how that ultimately breaks down, if I could. I don't know how that breaks down, because they're continuing to make these hikes, and I don't think there's an incentive for the regulators to hold that down, especially if they're going to grant an increase of 50% hike with it. Let me give you an example of some, and maybe you can work my way through this, because it's going to work out. She's going to have a subsidy, again, which falls back into why keep the premiums down if you're going to give them a subsidy. 60-year-old lady that was working. Her husband just lost his job, and she was covered under his insurance policy. She was covered under his. So now she doesn't have insurance coverage. And in the past, what she would have done, she's 62. He's retired. He went on Medicare. She doesn't have coverage. When we spoke to her, she said, I would have gotten catastrophic coverage, but I can't do that. I'm not permitted to under the ACA. So now I have to go out and buy coverage, and it's going to cost her, the cheapest rate she could get was $800. That means it's $9,600 a year she's going to have to pay. But then I guess what you're going to say, you're going to step in and say, well, we're going to provide a premium. We're going to give her a subsidy to this. Is that correct?
I think what I'd say is I don't know this particular situation. Glad to look into it. But I would say that for most people in America who were in that situation, they just, prior to the ACA, weren't guaranteed access to insurance, particularly if they were one of the 129 million Americans who had a pre-existing condition. So we think that's a really critical advance. We know that costs matter. We think the subsidies are important. We think the subsidies are a critical part of the law.
I appreciate it. I hope that we could do something, because at $10,000 a year, that's after taxes, how much she would be dedicating her income and that with what she's making. It's not a lot of money. But let me switch horses entirely on the thing, and I hope that you can get back to me on this other matter, because you haven't the first time. But and that is over site neutral. We've got a hospital complex in West Virginia that has been trying to get a permit for numbers of years. It took them several years to get this permit to build a ancillary hospital facility nearby. And as a result of being held up because of the government for water permits and road permits, environmental permits, it didn't occur until after November of 2015. And now as a result of that, by virtue of them now having invested $30 million into this under the site-neutral plan, they'll lose $4.5 million in revenue for that hospital. I'm asking if you could get back to us or have a conversation with us about how much more flexibility we can have to go beyond that, because it was not of their doing This was an arbitrary date of November of 2015 that was established, and I really would like to hear this, because it's going to have an impact. That $4.5 million that's going to cost is going to be borne by somebody else. And that's, once again, in rural America, what is going to impact is where we have the cost shifting, and it doesn't have to happen if we could just have a little flexibility in dealing with that site-neutral deadline date. Could you get back to me?
Yeah, and I think as you're aware, we're in the middle of a rulemaking process, so glad to get back to you and listen to comments, and particularly in this particular hospital situation, make sure we understand all the details. So yes, we'll get back to you.
Very soon. Thank you very much. I appreciate it. Yield back.
Chair, thanks, gentlemen, and now recognize the gentlelady from California.